Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with osteoporosis? Find out more right now. My guest this evening is Dr. Evan Siegel, a noted rheumatologist practicing right here in Montgomery County. Evan, welcome to Housecall.
Thank you, David.
So briefly tell our viewers about your professional background.
Well, I did my training in New York at Montefiore Medical Center, Boston University School of Medicine initially, Montefiore Medical Center for my internal medicine, NYU for rheumatology. I've been here in this community now for 33 years, practicing with Arthritis and Rheumatism Associates, with offices across the DMV from Fairfax all the way up to Frederick, but locally in Montgomery County in Chevy Chase, Rockville, and Silver Spring. And I have a special interest in osteoporosis and several other rheumatologic issues, and we've been treating it in this practice for probably a good 30 years at this point.
Congratulations. So briefly, encapsulate in one or two sentences your working definition of osteoporosis for our viewers.
Right. So osteoporosis, in essence, is a low bone mass and low bone quality based on a loss of calcium from the bone. That means that the bone is no longer strong. That's what bones are really for, right? They're to hold our bodies in place and keep us standing upright. And that is based on a lot of microarchitecture of little bits of bone going in all different directions. And when people develop osteoporosis for a variety of reasons, that microarchitecture gets broken down and thinner, and then predisposes to fracture. And in essence, really what osteoporosis is a risk for fracture.
How interesting. Now, our viewers understandably assume that bone as a material is a static state. It's far from it, though, isn't it? There's actually a dynamic going on there. Share with our viewers what goes on with our bones each and every day.
It's extremely dynamic. So bone is remodeling every single day, every minute of every day that we are just alive. And that's based on the opposing features of two different types of cells primarily, and those are called osteoblasts and osteoclasts. Osteoblasts are constantly rebuilding bone, and osteoclasts are constantly breaking down bone, actually forming almost like little potholes in the bone, eating away and causing little divots in the bone, followed by the road construction crew, which are the osteoblasts that fill up those little holes. About 10% of our bone is remodeled every year, slowly but constantly every day. That process is supposed to be equal. The rate of the osteoclasts eating away at the bone is supposed to be matched by the osteoblasts building backbone so that our bone density and bone strength stays the same. But in osteoporosis, the osteoclasts are winning the race and going much faster for a variety of different reasons, which we can talk about later, including menopause and others, but going much faster than the osteoblasts can keep up. And that's important to remember when later we talk a little bit about how we treat osteoporosis.
Drilling down to the different types of cells, osteoclast and osteoblast, is there things that can be toxic to each of those sort of cells?
Well, yes. I mean, we think about risk factors for osteoporosis, which are factors that are likely to speed up the osteoclasts or slow down the osteoblasts. For example, estrogen supports the activity of osteoclasts. So when when women go through menopause and lose estrogen or have lower levels of estrogen, the osteoclasts begin to speed up. Age can have an effect on osteoclasts, and so can a variety of other toxins that many of us may partake in. So alcohol has a negative effect on osteoclasts. Smoking has a significant negative effect on osteoclasts. So if people needed yet another reason to quit smoking, this is one of them. Caffeine also has a negative effect on osteoclasts and can promote osteoporosis by speeding up those osteoclasts and slowing down the osteoblasts.
What about genetics? Is that a factor?
Big factor. A family history of osteoporosis puts you at a much higher risk of osteoporosis, and especially if there's been a close family member who's had a hip fracture in the past. We think that actually significantly increases the next generation's risk of osteoporosis.
And what about ethnicity? Does that matter?
We see osteoporosis much more in Caucasians and especially Asian populations, a little bit less in the African American population. So that does play a big role.
And what effect does exercise have on bone dynamic?
Well, you know what? That is one of the key issues, and I'm really glad you brought that up because exercise plays a big role in maintaining bone density. We recommend as part of a basic treatment to prevent osteoporosis or to treat people who have osteoporosis at least 15 to 30 minutes of weight-bearing exercise every day. It seems like that gravitational pull during exercise on the bones actually has an effect on the cells to take in calcium and incorporate calcium into the structure of the bone. In fact, I mean, there's sort of a triad. I like to talk about the three things that help to prevent osteoporosis or treat it initially when we make that diagnosis. I call it kind of the three-legged stool that holds up your bone density, and that is exercise, as you mentioned, 15 to 30 minutes per day, calcium, appropriate amounts, and we can talk about what those are later if you'd like, and vitamin D intake, because without vitamin D, you cannot absorb calcium, and vitamin D deficiency plays a big role in predisposing to osteoporosis.
Are there any disease states that have a higher risk of developing osteoporosis?
Certainly. So a variety. Anything that...
And don't forget, I'm a gastroenterologist.
Right. First of all, anything that requires steroids. So prednisone is a big risk factor, or any type of parenteral steroid or injected steroids, all are a very significant risk factor. So that means any inflammatory diseases may predispose to osteoporosis, and that includes inflammatory bowel disease like Crohn's disease and ulcerative colitis, but also rheumatoid arthritis and psoriatic arthritis, which may sometimes require steroid therapy. And even in and of themselves, those diseases actually predispose to osteoporosis. Of course, some endocrine diseases would be highly associated. So hyperparathyroidism and some forms of thyroid disease predispose to osteoporosis. Also, endocrine disorders that involve excessive steroid production. So inflammatory diseases, and then also sort of medications, and there are some variable thoughts about this, but other medications like proton pump inhibitors, which are used to treat stomach ulcers and peptic ulcer disease and gastroesophageal reflux disease, may also predispose to osteoporosis.
Excellent. And I would also add in my discipline, celiac disease.
Yes.
Wheat allergy.
Yes.
Because of malabsorption of calcium and vitamin D.
100%. And any other diseases that would cause malabsorption
Sure.
also would lead to osteoporosis.
And I should tell our viewers that quite commonly when I diagnose new cases of Crohn's disease or ulcerative colitis or celiac disease, I then refer the patients to Dr. Siegel to do osteoporosis screening and management.
Very, very important, and certainly in anybody who requires low doses, even low doses of prednisone. We think even doses as low as 5 milligrams per day of prednisone can predispose to osteoporosis. Also, another thing, men who are treated for prostate cancer, who are often treated with hormone-suppressing therapies, can be at high risk for osteoporosis as well. And I should mention that men do get osteoporosis as well, and should be screened for osteoporosis over age 70, but it's often forgotten that this is a disease of men as well.
You mentioned vitamin D as being part of the 3 components of osteoporosis. And given that you can either take vitamin D exogenously as a pill, or our skin can synthesize it. I guess the question I would have is, given people that reside in southern territories where there's more sunlight, they presumably have more skin production of vitamin D. Has there been any data that shows that there's therefore a lower incidence of osteoporosis in those states?
It is protective in those areas to some extent, but remember, vitamin D and calcium absorption is only one small feature of osteoporosis prevention. So the answer is yes. Really in our area and in more temperate climates, the question, and in those areas as well, is the very delicate balance between getting enough sunshine to get vitamin D and avoiding skin cancer. Right. So
Sure.
I often tell people 15 minutes of unprotected sunshine is probably sort of a good balance on that. And all of us have been very protective these days in terms of sunscreen, and actually the use of sunscreen blocks the production of vitamin D. So it is a very delicate balance. And that's why I think we find a lot of vitamin D deficiency in this population now, and often that requires exogenous vitamin D or vitamin D supplementation.
We're going to pause briefly for a public service announcement. More with my guest, Dr. Evan Siegel, discussing osteoporosis. We'll be right back.
Get it, slip it, cuff it, check it. Talk to doctor now and share it. Get it, slip it, cuff it, check it. Talk to doctor now and share it. Gonna get it, gonna slip it, gonna cuff it. Check it, talk to doctor and share it. Gonna get it, gonna slip it, gonna cuff it. Check it, talk to doctor and share it.
Get it, slip it, cuff it, check it. High blood pressure silently affects millions of Americans. Staying on top of your blood pressure is as simple as these 4 easy steps. Self-monitoring is power. Visit manageyourbp.org to learn more.
We're back. My guest this evening is Dr. Evan Siegel, and we're discussing osteoporosis. Evan, when we paused for the break, we were discussing the overview of osteoporosis. Now let's go on to discuss, how do you go about diagnosing this condition?
Okay, well, first of all, we think about the people who have risk factors, and those are the ones that we want to screen. And how do we screen for osteoporosis? With a test called a DEXA, which stands for dual energy X-ray absorptiometry. So this does use X radiation, but very, very minimal X-ray radiation, much, much less than just getting a chest X-ray. Who do we think should get this study? Well, first, let me describe the study. It's very easy to do. A patient just lies on a table, and a little scanner goes over their spine and hip. We focus primarily on the bone density, or the amount of calcium in the bones in the spine and the hip generally, but we can also screen the forearm. There are two types of bone densitometry units. One is a full body DEXA, which is the type most radiology places would use and that we use in our office. Some smaller offices might use a peripheral densitometry unit, which measures the density of the heel or the finger. Those have been shown not to be as accurate or as sensitive as the larger studies. When this is done, two different sources of radiation go through the bone, and then a sensor measures how much is absorbed, and the amount that is absorbed correlates to the amount of calcium and the density of the in the bone and the density of the bone. Who should be screened? Women over the age of 65 or estrogen deficiency, which means after menopause. So we do recommend that most women get screened in that perimenopausal period, right around the time of menopause, to get a baseline, and then probably every 2 to 3 years after that, depending on their bone density. Men over age 70 should be screened. Anybody who is taking prednisone for more than 3 months should be screened. Anybody who has hyperparathyroidism should be screened. And anybody who's been found to have any vertebral deformity. So maybe they have a chest x-ray or an x-ray of their lower spine, and they're found to have a vertebral fracture or some sort of deformity, they need to be screened for osteoporosis as well. When we look at the DEXA study, we get something called a T-score. The T-score tells us how many standard deviations that patient is away from the mean, and the mean is a young 30 to 35-year-old woman with peak bone density, right? So the T-score comes out as a number that is either negative or positive. If it's positive, that's good. That means your bones are the same density as a 35-year-old or even better. If it's negative, then negative down to -1 is still considered normal. So 1 standard deviation from the mean is still normal. If it's -1 to -2.4, that's called osteopenia. That means low bone density, but not quite osteoporosis, not quite so severe that we're really worried about an imminent fracture, but a higher risk of fracture than the general population. And anything that's -2.5 or lower, more negative, is considered significant osteoporosis with a high risk of fracture. We use one other measure to determine those people who have osteopenia, whether they need therapy or not. Anybody with osteoporosis, -2.5 or lower, definitely does need to be treated or at least consider treatment. If your bone density is from -1 to -2.4 or osteopenia, we use something called a FRAX score, which takes into account lots of different risk factors. Have you had a first-degree relative with a hip fracture? Do you have rheumatoid arthritis? Are you on prednisone? Have you had a previous significant fracture? And a number of others. And we take that and it's run through a computer algorithm along with the bone density to determine what the risk for fracture is in the next 10 years. So we can actually predict what an individual's risk for fracture is in the next 10 years. And we do 2 measurements. One, for any type of osteoporotic fracture. Osteoporotic fractures are considered vertebral fractures, wrist fractures, and hip fractures. Or any other fracture is sort of mixed into that as well. And we say the general population has about a 20% chance of any one of those fractures. So if you have more than a 20% chance of one of those fractures, then we say you're a candidate for therapy. We also measure the risk in the next 10 years of hip fracture. Now, hip fracture is a life-changing event. People who have a hip fracture often will have permanent disability, often need surgery, and there's actually a significant increase in mortality in the year or 2 after hip fracture. So we say that we will not accept much risk. So say the general population has about a 3% risk of hip fracture. So if anybody has more than a 3% risk of hip fracture in the next 10 years, then they are candidates for therapy. And that's what we use the DEXA for predicting who needs therapy.
So let's say you've diagnosed somebody with the milder form on the continuum, osteopenia. What kind of treatment options do you offer them once the diagnosis has been made?
Right. So if they have osteopenia and their FRAX score is actually in the normal range, then we recommend conservative measures. And that's that three-legged stool again. Exercise for 15 to 30 minutes every day, appropriate calcium intake. And we strongly recommend that that intake come from food rather than supplements. And the amount of calcium people should take should get in is 12 to 1,500 milligrams per day from all sources. So that means if you're taking in 500 milligrams of calcium as a supplement, you need to get another 500 to 1,000 from food, right? And I often give my patients a calcium-containing foods list, but this is very available on the internet to look and see how many milligrams of calcium you get from various different foods. So for example, a yogurt will give you 250 milligrams, a glass of milk, 300. You want to mix and match those foods to get 12 to 1,500 milligrams. And if you say, hey, no matter what I do, I'm not getting in more than 700, then 500 milligrams of a calcium tablet is helpful. As far as vitamin D, we generally recommend about 2,000 units of vitamin D for people who have osteopenia taken daily, and that's just over the counter. If people have osteopenia with an abnormal FRAX score, then we use the same treatment algorithm that we use for people with osteoporosis. We can talk about that more if you'd like.
Let's go on then to discuss osteoporosis. What are the treatment options? Because I know they've evolved over the years.
Have they ever? Yes. We have several more treatment options than we had over the last 10 or 15 years. So first of all, the same three-legged stool applies to people with osteoporosis. So we recommend those basic conservative measures. And then there are two different types of treatment. There are anti-resorptive therapies and anabolic therapies. Anti-resorptive therapies prevent further loss of bone, further loss of calcium from the bone. How do they do that? They interfere with those osteoclasts that we talked about. Generally, they slow down their activity so that the osteoblasts, the bone building cells, can catch up. So there are several types of anti-resorptive therapies that we use. The anti-resorptive therapies include something we call selective estrogen receptor modulators. These are drugs like Evista or raloxifene or tamoxifen. That's, of course, only for women, and these don't have much of an estrogen effect like they would have on various different things like hot flashes and things like that, but do have a selective effect on the osteoclasts and the bone loss issues associated with osteoporosis. That's generally used only for people with very, very mild osteopenia. Then we have the bisphosphonates. The bisphosphonates are the ones everybody's heard of: Fosamax, which is alendronate, Boniva, Actonel. These are oral medications that slow down the osteoclasts, inhibit the osteoclast function. The problem is that they can have side effects, particularly GI side effects that affect many people. So anybody with reflux, we try to avoid the oral bisphosphonates, because one of the bad side effects is if the bisphosphonate pill refluxes out of the stomach and into the esophagus, it can burn the esophagus and really both cause damage, but also significantly exacerbate those reflux symptoms. So we do have an IV form of bisphosphonate as well, called Reclast or zoledronic acid. That's given as an IV infusion once a year, and that also inhibits the osteoclast activity. We generally use bisphosphonates for 3 to 5 years because it was determined that if you use it for longer than that, you can over-suppress the bone. And when you over-suppress the bone, you can see some problems that are well known to be side effects of bisphosphonates, which is an atypical fracture of the femur, extremely rare, but can happen with overtreatment, and osteonecrosis of the jaw, which is poor healing of the bone in the jaw after an extraction or an implant. So we are very careful to warn people about that. Additionally, we have a medicine called Prolia or denosumab. Denosumab is a biologic agent, so that's been around now about 10 years, but that's one of our newer agents. And that actually is given injectably once every 6 months, so it bypasses that GI tract as well. And that both inhibits the osteoclast activity, but also stops them from proliferating. So it decreases the number of osteoclasts and decreases the activity of the osteoclasts so that we get an even more potent suppressive effect on that bone resorption. On the other side of the coin, for people with more severe osteoporosis, we might use anabolic agents. These are agents that build bone. So these are parathyroid hormone analogs like Forteo or Tymlos, which actually give a tiny little dose of parathyroid hormone. You say, wait a minute, you said parathyroid hormone causes osteoporosis, but if you give it as a tiny little burst, it actually stimulates the osteoblasts. So then we're working on the other side. We're kicking the butt of those osteoblasts and making them build bone a little bit more effectively, fill in those potholes quicker. So that's that type. And then more recently, in the last few years, we've had another anabolic agent called Evenity. This is another biologic agent, complicated mechanism called an anti-sclerostin inhibitor. But in essence, it both it kicks the osteoblasts into high gear, especially in the first 6 months of using it, and then also inhibits the osteoclasts. And that's given once a month for just 12 months. And then we follow it with something to maintain bone density like Prolia or a bisphosphonate. And that's the recipe for treatment.
If somebody sustains a osteoporotic fracture of their spine, vertebrae are collapsing, are there any surgical options to restore that spinal integrity?
Yeah, they are. They're a little controversial. They are mostly used. So these are injections, basically, of cement into the fractured vertebral body. So if it's collapsed, you can inject cement. That's called vertebroplasty, or you can put a balloon in, blow that bone back up to a more normal shape, and then put cement in, and that's called kyphoplasty. Work best for helping with the pain after a fracture. And if there's been a real collapse, doing the kyphoplasty may bring back some more normal anatomy, which otherwise doesn't happen.
Evan, thank you for an excellent interview. Thank you to my team at the station. And most important, thanks to you, the viewer, for joining us this evening. Let us know how we're doing. You can reach me at my practice website listed on this screen. Look forward to seeing you then next time for another edition of Housecall. Good evening.